Thank you for joining this edition of CMEOCast entitled Switching and Monitoring Your Patients with RRMS. Dr. Fred Lublin has been kind enough to share his thoughts and insights with us today. Dr. Lublin is Professor of Neurology, Saunders Family Professor of Neurology, and Director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis at the Icahn School of Medicine in New York, New York. Our learning objectives for today's CMEOcast are to develop treatment plans based on clinical characteristics of patients with RRMS, to assess patients for disease activity and switch when response is suboptimal, and finally, to integrate strategies for delivering patient-centered care when managing your patients with RRMS. Welcome, Dr. Lublin.
So let's start with a case. This is James, a 35-year-old male African-American diagnosed 4 years ago with MS. He was started on glutamer acetate with a good response. However, in the past year, he's had 2 relapses of optic neuritis and episodes of facial weakness, numbness, gait difficulty, bladder dysfunction, and paresthesia. He has a history of smoking. So based on the information provided, how would you treat James? So here are some of the predictors of a poor prognosis in MS, and conversely, the opposite would be predictors of a better prognosis. Now, one of the important things to remember here is that MS is an extremely unpredictable disease. And while I'm going to give you these predictors, this is for groups of patients. Predicting for a given individual is extremely difficult and often wrong. So what are some of the demographic and environmental factors? Well, older age carries a poor prognosis, male sex, not of European descent. So this is interesting because Caucasians get MS most frequently, more frequently than any other racial group. But most other racial groups, when they get the disease, have it more severely. Low vitamin D levels are associated with a poor prognosis, although that doesn't tell us yet whether supplementation improves the prognosis. Smoking. Here is a modifiable risk factor that one can use to improve the prognosis. Smoking makes MS worse and more often leads to disability. And any comorbid conditions, hypertension, vascular disease, things of that sort, even obesity, can lead to a poor prognosis. Clinical factors, well, if you start out as primary progressive MS, you're more likely to have more disability. Higher relapse rate early in the disease can lead to increased disability. Shorter interval between the first and the second relapse carries a poor prognosis. Involvement of the brainstem, cerebellum, and spinal cord at onset is a bad sign. Poor recovery from the first relapse, a higher expanded disability status score at diagnosis, polysymptomatic onset, and early cognitive deficits. In terms of MRI, high number of T2 lesions, high number of T2 lesion volume, multiple gadolinium enhancing lesions, infratentorial lesions, spinal cord lesions, whole brain atrophy, and gray matter atrophy all carry a poor prognosis. In terms of biomarkers, well, the MRI is a biomarker. Oligoclonal bands in the spinal fluid carry a worse prognosis. We're looking at the levels of neurofilament light chain. We think that it has an effect on prognosis, but we need more information on that. And changes in the retinal nerve fiber layer on optical coherence tomography also carries a poor prognosis. And so conversely, you have, if you're younger, female, start out with sensory symptoms, you carry a better prognosis. So now let's look at James' MRI findings. So it's a subsequent MRI, which reveals 4 new lesions in the spinal cord and the periventricular white matter, and 2 of those lesions enhance. So let's take a look at the factors to consider in treatment decisions. This has become a time-consuming, complicated issue of multiple sclerosis, in part because there's so many factors to be taken into consideration, and in part because therapy needs to be individualized, and in part because we have multiple choices of disease-modifying therapies that we can utilize. So first, let's start with an evidence-based approach, which uses the data we have showing us the efficacy of the given agents. Unfortunately, we don't have as much comparative efficacy data as we would like, and one should never compare across studies. If you want to know whether one agent is better than another, they have to be tested within the same study. And then safety. Safety is very important because our agents have varying safety features involved with them, and patients are very concerned about safety. They frequently ask us, how long has that drug been around? What are the safety effects? They are concerned about what they put in their body. We have tolerability. Different individuals respond differently to side effects, whether it be GI side effects or flu-like symptoms or things of that sort. There's an issue of convenience. Convenience involves route of administration. Some people may be okay with taking an injectable agent, others don't want to give themselves injections. Some may prefer to come into an infusion unit for a short period of time every 4 weeks. Others may prefer a longer infusion, but have it done every 6 weeks. Some may prefer to take a subcutaneous injection at home. Monitoring is an important aspect of what we do. All of our agents require some sort of monitoring for the most part, some more than others. Some have monitoring that goes on for years after they discontinue the drug. So the individual has to be partnered in this so that they participate in the monitoring and cooperate so you can get the studies you need to make sure that blood counts and liver function and the other things that we need to monitor. In women, pregnancy issues are a big part of the discussion because we don't want individuals getting pregnant while taking any of our agents. Some are more of an issue than others, but family planning is a big part of the initial conversation and an ongoing conversation as we move along. In general, I like individuals to commit to taking therapy for at least a year before they start to think about family planning issues, or in some cases, we'll have them start their family planning right away and put off taking disease-modifying therapy. Again, this is part of the individual conversation that you need to have. Cost is an annoying part of this conversation, but the drugs are very expensive. And insurance companies have their own guidelines on what they'll pay for and what they won't. And this frequently interferes with what the clinician and the patient think is the best drug for them. Patient preference, of course, is an issue. The patient has to be on board with what you're giving them so that they take the medication. Physician experience plays a role in general, but we like physicians to have experience with all of our agents. And then, of course, response to therapy is a key aspect that we'll talk about more as we monitor it. And mechanism of action, MOA, can be very important when considering therapy, especially when you take into consideration comorbid conditions that may interfere or put increased risk on certain mechanisms of action. Personalizing treatment is key. You want to start early with the most effective treatment appropriate to the window of presentation. That is where the patient is when they come in. It's hoped for that in the future, we will have biomarkers that will allow more precise, personalized disease-modifying therapy selection, and even to allow us to pick who the responders and non-responders are going to be. Absent that ability, which is not the case now, clinicians should have a plan to determine suboptimal responders after a reasonable time on a first therapy. That means having an approach for switching or escalating the therapy, and consider more aggressive starting therapy for patients with either silent advanced disease or early signs of poor prognosis. Now, these things are easy to say, but we don't have a lot of data to tell us what is the suboptimal responder to almost any of our agents. And so this is something that's up to the clinician to try and figure out until we have more data. So in general, at the start of therapy, there's the high efficacy agents, which have a higher risk associated with them, versus the escalation approach, which has a lower risk. And this is part of this balancing of efficacy and safety. And it's a combined decision between the clinician and the patient. Now, the reason why we have escalation therapy is because there are safer agents and because all of our agents have worked in some individuals. So in the escalation approach, you start with one of the first line agents, you monitor the treatment response, and if they're not doing well, you move to a higher efficacy agent. Starting with a high efficacy agent, you start with the higher efficacy agent and you get the response you're looking for, hopefully. And then what's not been studied yet, but is something under consideration, is at some point in the future, going back to a lower risk agent, just so you don't keep someone on a high efficacy agent for long periods of time. That particular approach has not yet been studied, but it is something that we're thinking about. In terms of switching, again, you need to have a threshold of activity, whether it be clinical or maybe even MRI, in which you say, well, I don't think the patient's getting enough response in this therapy, I'm going to switch them to another. In general, you should not switch horizontally, that is from one first line agent to another, but rather go up to a more efficacious agent. And so if one's on a first line agent, you could theoretically go up to one of the oral agents or one of the infusible agents. But ultimately, the patient is going to make the choice. Your job as a clinician to educate them, give them the information, discuss with them adverse events, risk versus benefit, the treatment goal, and the severity of their disease at the time you see them. The patient's going to think about how this fits into their lifestyle in many different ways. Monitoring, once they're on treatment, well, you certainly monitor for relapses. And while we don't have hard fixed guidelines, more than one relapse a year is probably more than they should be having and would consider changing therapy. Severe relapses, even more so, and incomplete recovery from relapses also suggests that you should have greater concern. When MRI, again, no hard and fast rules, but if there's a continued activity with new lesions, one should be concerned that the therapy may be suboptimal. And looking at EDSS even more so, if an individual is progressing on a given therapy, worsening independent of relapses, then that therapy is probably not working for them and they need to move on to something else. This may depend on what EDS level they're at, because the higher the EDS level, the more they change, the worse their level of disability. So let's go back to James. He's 35 years old, he's African-American, diagnosed with MS 4 years ago. He initially did okay on glutamer acetate, but now he's had 2 relapses and has significant issues with optic neuritis, facial weakness, numbness, gait difficulty, bladder dysfunction, and paresthesia, and he's a smoker. And you saw his MRI earlier. He has new lesions, including the spinal cord. Based on the information provided now, how would you treat James? So the hope for his outcome is to reduce the number of relapse episodes and the accumulation of MRI lesions. You want to slow disease worsening, and you hope for improvement in his disability, although improvement is a hard one to get. So goals, early treatment is beneficial. One should individualize therapeutic strategy based on the patient factors we discussed, the disease factors, how aggressive the disease looks, and the type of the agent, the drug factors. One should continue to monitor for disease activity. And in patients with a suboptimal response, you should consider switching the therapy to a higher efficacy agent. I thank you for your attention to this program.